رز. Thank you. Good morning to everyone participating on the scientific program during the annual Congress, 69th annual Congress here in Almaty in Kazakhstan. And I would give the floor to our president, to the rector of our university, Asfendiarov Kazakh National Medical University, Shoranov Marat Edegevich. The floor is yours.
Thank you, Janice. As a rector of this university, it is my honor to see you all today here in our university. And we are very glad to host this event. One of the activities of the International Association for Dental Students. And as far as I know, this organization has a great history starting from 1951. And now students from all around the world has a great chance to share their experiences, to share their practices, and to share their thoughts, how to improve the educational programs, as well as how to get more prepared for the real practicing world. And nowadays in our university, we have approximately 1,200 students who are studying dentistry and planning to be a dental doctors in the future. And as a general doctor, I'm a neurologist, but I was always saying that everything starts with the communication, and you guys are making the communication easier, because when people can smile and with bright smile, it's first sign of health in general, because we know that if a person has a problem, dental problems, and other problems will appear, such as stomach diseases, metabolic syndromes, etc., and so on. So in general, as a part of the medicine, you guys are making a very, very important job in order to prevent some other serious complications with the health. And as far as I know, few of our last meetings went online, and today you guys have a chance to see each other in person. And the more than 35 members of the association came to Kazakhstan from more than 20 countries, and that makes this event very, very, important. And I wish you all have a fruitful discussion today. And as we know, during last 2 days, you've got also some meetings, and Zenibek was elected as the vice president of this association. And for our university, it's also a big honor to have students who is taking such an important position. And this also comes with the commitment. And as a rector of this university, I would like to say that Kazakh National Medical University is ready to support all the activities and provide all the necessary support to the association whenever it will needed. And we will keep in touch, and I hope that all the resolutions and recommendations you will make will help not only us, but other universities, your universities, to improve your programs, to raise the dialogue between the students and professors easier. And actually, you guys are a good example for other disciplines such as general medicine, epidemiology, etc., and so on. So I wish you all the best of luck in all your endeavors. Wish you have good memories from our beloved city of Almaty. Hope you guys have a good impressions of our university as well, as we are the oldest university in Kazakhstan. We have more than 20 years of our great history, and this Hall of Fame also is very important place, and it has a special spirit of our teachers, of the staff who made a great impact on our development. And what I can also tell, that your generation lives in a modern world which has lots of global challenges, and I have no doubt that your generation will handle everything in a good way. And I just want to tell you that whatever you do in your future, you have to be sure and committed to make it better than the previous generations. That is your mission. So wish you all once again best of luck. Welcome to Almaty. Have a good rest of your time in our beloved city, and I hope you guys had a chance to see our city, and or maybe you went to the mountains, I don't know, but you're always welcome, and our university is very open. So you have a very intensive program today, and I think as a vice president, Denis will continue this meeting, and once again, best of luck. Thank you.
Thank you very much, Marat Sedegevich. The floor is given to the Dean of School of Dentistry, Basenbek Perdebekovich.
Hello, dear colleagues, dear dental students. I'm glad to see you in all our university, and I'm glad to see you in our university walls. We always help our youth students, and I want to say thank you, Abdul Hamid, President of International Association of Dental Students, for taking our country places in this Congress. And I want to поздравить our students, Abay and James, your new vice-presidents. I want to say good luck our students. Thank you for attention. Thank you very much.
Thank you very much, Basenbek Perdebekovich. The next floor is given to the head of Kazakhstan Stomatological Association, Professor Myra Kopaeva, general sponsor of this annual Congress.
Good morning, dear college. Доброе утро всем. Günaydın. Guten Abend. Уважаемые коллеги, я рада вас еще раз приветствовать. И сегодня мы уже 4-й день видим ваши лица. И хочу сказать, я даже не ожидала, что наши молодые коллеги будут так активно работать. Вчерашний день меня впечатлил в особенности. Я была на Генеральной Ассамблее. Я бы хотела вообще присутствовала дольше времени. Но вчера вы своей работоспособностью нас впечатлили.
Good morning to everyone. I would like to to give my appreciation to organizing committee, to EXCO of IDS, and also to local organizing committee from yesterday, because yesterday was 12 hours General Assembly. And I want to express my appreciation and say thank you for the opportunity to be here.
Я хочу выразить свою признательность и благодарность руководству IADS за то, что вы выбрали местом проведения данного форума наш город и доверили это нашим молодым коллегам.
I would also say thank you for all EXCO members of IDS and also to the delegates of International Association of Dental Students that you've chosen the place for 69th Annual Congress is Almaty.
И вчерашний день он очень вдохновил и нас, коллег старших. Я не только являюсь председателем правления Казахстанской стоматологической ассоциации, я еще работаю профессором именно в Казахском национальном медицинском университете.
Yeah, I was impressed from yesterday from the General Assembly, and I work not only like the head of Kazakhstan Stomatological Association, but also the professor in the School of Dentistry in Asfendiyarov Kazakh National Medical University.
И думаю, вот площадка, на которой мы собрались, это станет для вас прекрасным местом для объединения дальнейшего, станет местом для того, чтобы вы обменялись мнениями, появились новые идеи, новые проекты. И все это будет способствовать развитию стоматологии мира.
Today is the day where you can give your experience and also get experience from other people. And I hope that everyone will get huge insights from this scientific program from today.
Казахстанская стоматологическая ассоциация всегда будет поддерживать и поддерживала с первых дней наших молодых коллег КАДИ.
Kazakhstan Stomatological Association will always supports and always helps to young generation, to young dentists in the Kazakhstan.
Работала большая команда ребят, я думаю, вы это видите.
Local organizing committee had been working very well.
И спасибо вам за доверие, которое вы оказали, избрав Жениса и Абая на позиции. Я думаю, они оправдают ваше доверие.
And thanks for your effort. Thanks for your appreciation to us, because Vice President for Science and Research, Cengiz, it's me, and the Abay Kalamtai, Vice President for Finances, will work, will effort, and will negotiate with in the future 1 year. So thank you for the opportunity for our young dentists.
Вчера я обратила внимание, когда задавали вопрос по имени Женис. Они работали в основном втроем и большая команда. Простите, я всех не смогу назвать, но я просто хотела бы сказать. Абай – это имя нашего великого казахского просветителя, акына, законодателя первой, допустим, именно русской письменности, вот на кириллице. Это был Абай, великий сын казахского народа.
And also, by the way, Abay is the famous, outstanding poet in the Kazakh culture, and he was the first who introduced Russian language in Kazakhstan, and also the Abay was very famous and still famous nowadays. So Abay is Abay Kalamtai, and Abay poet is very famous persons, yeah, in Kazakhstan.
Женис в переводе с казахского означает победа.
Zengiz is translated like victory from Kazakh language.
Арман переводится Арман мечта.
Arman is translated like the dream.
Вот я поэтому думаю, мы старшее поколение, то есть через мудрость Абая, через победу мы достигнем своей мечты, чтобы Казахстан был узнаваемым везде, во всех странах мира. Спасибо за внимание.
And with dream and victory, we can achieve more heights in the future. Thank you for the attention. Thank you very much, Professor Maya Kopayeva. And the next floor is given to past immediate Vice President for Science and Research, İrem Türkan.
Hello, my name is İrem Türkan, and for those of you who don't know me, I am the IADS Vice President of Science and Research, and we would like to welcome you to the IADS Annual Congress Scientific Program for today. And I would like to thank all of our doctors who accepted our invitation to share their precious experience with us. And thank you all for patiently waiting for us today. I hope you enjoyed all.
And we start the scientific program with Dr. Yulia Menchisheva's presentation. And the name of the presentation, use of platelet plasma in maxillofacial oral surgery. The floor is yours.
Dear students, I'm delighted to welcome you to annual Congress, which is held in our university. So today we will speak about some platelet concentrates that are PRP, PRF, and PRPP, which means plasma, fibrin, and powder. And I want to ask some questions. Have you ever used it in your daily practice? Probably some of you know these methods. Please raise your hands. If you know the theme, don't be shy, yeah? Raise your hands. So you will be our advisor in some questions. So let me check, is it? Yeah, it's working. So human platelets concentrates, it's extracted from patient's own blood for treatment purposes, as you know. And it's used not only in dentistry, oral medicine, maxillofacial surgery, but also in plastic surgery, cosmetology, traumatology, gynecology, etc. So we will see how to use it, how to obtain all these platelet concentrates. But before, I want to play a little game. Imagine that we have two groups, for example, on the left side and on the right side, you two groups of surgeons, and you using PRP and PRF in your practice. You have the same patients. It is patient that on the slide, okay, let's see it. It's patient with renal failure. So this group of surgeons made operation, and you also made operation to this patient, but in this case, wound healed faster. I mean, post-operation wound. And in your case, wound healed longer. For example, 1.5 months, and here 3 weeks. So at the end of this lecture, you should answer why here this group was successful and this group wasn't successful. But before answering this question, we should remember about function of platelets. And if you know this, it is a first cell type that arrive at the site of tissue injury. And also it's particularly active in the early inflammatory phases. They play a role in homeostasis through cell membrane adherence, aggregation, clot formation. So platelets mediate these effects through degranulation. And what types of granules have these platelets? Alpha and dense granules. In alpha, there are a lot of different growth factors that gives these positive results in treatment. And on the other hand, dense granules have different mediators as serotonin and histamine, which increase vessels permeability and tissue perfusion. So here a slide with all growth factors. I will not stop on this one. So let's move on and speak a little bit about history. Who investigated these methods? Who was the first? And honestly, the first was the dentist, the maxillofacial surgeon. It's Robert Marks. He is a professor in University of Miami, and he pioneered these new concepts and treatments. And he said, if you want to get positive results, the count of platelets in platelet-rich plasma should be counted, should be 1 million and 1 milliliter. If you will have more or less than this count, you will not have positive results during different procedures. Talking about classification, if you will see different articles, books about these platelet concentrates, there are a lot of classification of blood derivatives. So first of all, I want to stop on PRP. It is platelet-rich plasma. It could be pure and leukocyte PRP. What it means? Pure platelet-rich plasma is plasma without white blood cells and with a low density of fibrin network. Leukocyte PRP, it is plasma with white blood cells. So PRP, it is a liquid form. The second type of platelet concentrates is PRF. It's platelet-rich fibrin. It's also divided into two groups like pure PRF and leukocyte PRF. The same classification. In pure, there is no leukocytes, and an LPRF, there are some white blood cells and high density of fibrin. By the way, there are another generation of LPRF, which is called APRF, which is mean advanced, and injectable form IPRF. So the difference we will discuss. And the third type of platelet concentrate is platelet-rich powder. So it looks like powder. We could obtain it by freeze-dried method or lyophilization, or just by drying plasma. What's the main difference between PRP and PRF? If you remember, it resides within their fibrin architecture. So in this picture on this slide, we see PRF. And in PRF, network gradually builds up during centrifugation and in the absence of anticoagulant agents. This results in a dense fibrin structure, which is act like a network in which platelets and white blood cells are interrupted. So that's the difference, and also difference in preparation of these concentrates. Let's start with PRP. How to prepare it probably you will use it in your daily medical practice. So it's prepared via two-step spinning, two-step centrifugation. And we need to use tubes with anticoagulant. At the first step, after first centrifugation, after first spinning, we see 3 layers that are demarched. So that's how it looks. On the top, it is plasma. On the bottom, it is red blood cells. And in the middle, it is buffy coat, which is consist of leukocytes, I mean white blood cells, and platelets. Then we use second spin, second centrifugation. And if you want to obtain pure platelet-rich plasma or leukocyte platelet-rich plasma, you need to use different methods. That is why there are 2 methods of obtaining pure PRP method and buffy coat method. What's the difference? So for the production of pure PRP, you need to take upper layer from the tube and superficial buffy coat and transfer it to empty sterile tube. But if you want to gain L-PRP, you need to take entire layer of buffy coat and few red blood cells that are in the bottom and transfer it also to the tube. Then you make centrifugation again and obtain plasma. So the lower third is platelet-rich plasma, and upper 2/3 is platelet-poor plasma. And you need to remove poor plasma and suspend the platelet pellets in a minimum quantity of plasma just by gentle shaking the tube. How it looks in real life. So look at this picture. First of all, we take blood from the patient, centrifugate this plasma, After first centrifugation, we have 3 layers. Then, кто-нибудь наверху есть видео включить? Вот нижний квадрат. Попробуйте запустить, или оно не запускается. I had some video. I'm not sure will it work or not. So after first centrifugation, we took plasma and make the second spin, and that how it looks. Platelet-rich plasma. It's on the left side, as you see. I think that video is not working. Okay, let's move on. So, first question that you should ask, what spin should I use? And how long should I spin this blood, right? So there are a lot of researchers, different investigations, articles, trials that show us different time and different speed. And as you see, this review of results of different researchers that obtained PRP with different methods. And when you see the method of obtaining and speed, you will see abbreviatures such as RCV and RPM. Like one author will say, I obtained it by this force, and other author will say, I obtained plasma by speed of rotations per minute. So what the difference between RCV and RPM? RCV, it is a relative centrifugal force, and RPM, it is rotations or revolutions per minute. So RPM, I think it's very clear, but what is it RCV? How to understand how much it in RPM? So there is some equation formula that could move RCV to RPM and otherwise RPM to RCV. So some doctors draw up their protocols by using RCV, G-force, and while others use RPM. So it depends on from which country they are and which centrifugal machine they use. So that's the difference, but you need to choose optimal speed. So that's the different types of centrifuge machines that we use in practice. So what's the optimal parameters? At first spin, when we took blood, we need to make first spin. This spin should be soft. In average, this values from 160 to 280 in G-force. But if you use RPM, it will be 1030 and 1500 RPM. So first spin is soft. The time of spin is 5 minutes. The second spin should be hard, should be high. So in G-forces, it will be from 400 to 600, and in RPM, it will be from 2000 to 3,500 for 10 minutes. So remember, first spin soft, second spin high. If you will make too long centrifugation or force will be too high, all platelets will be damaged and you will not achieve positive results. So therefore, remember it. Another questions, there are a lot of tubes in markets. So which anticoagulant, which tubes you should use? The importance lies in choosing an anticoagulant capable of preserving the platelets best possible functionally, integrity, and morphology. So we can use tubes with sodium citrate or with acid citrate dextrose solution, ACDA, or sodium heparin. And remember, don't use tubes with ADTA. It is also the type of anticoagulant, but it's not recommended for PRP gaining due to its platelet fragmentation ability. So you will just destroy these platelets. And if you remember course of physiology, all these anticoagulants blocking transferring prothrombin to thrombin. So if we use this tube with anticoagulants, our platelet is not active. How to activate it? That's the other problem when young doctors use different type of platelet concentrates in their patients and don't achieve results, and then asking why it's not working, why something is not healing good, etc. So because PRP not activated, PRP activation prior to injection is another parameter that requires further discussion. So it could be activated by thrombin, by calcium chloride, or if you inject it in soft tissues, it will activate by itself. Let's move on to PRF. So PRF, it is a single-stage centrifuge product that does not require the addition of various different chemicals. It means that you use tubes without anticoagulants. So there are different types of PRF, like I said before, LPRF, APRF, and injectable form. Here are the parameters that you will use to obtain all these forms. Here are some difference between LPRF and APRF. So advanced PRF is a variation of LPRF, and it has more concentrated, more eventually distributed growth factors and fibrin site. Protocol for preparation for PRF clots. So you will use PRF clots and PRF membranes. If you need obtain PRF clots, you take blood, 2 tubes without anticoagulants. After the first 2 tubes blood are collected, immediately place it into centrifuge opposite to each other to ensure that centrifuge is properly balanced. So centrifugation should be at 400 G-force or 2700 RPM, at least 12 minutes. Then take the fibrin clots out of the tubes and separate them from the red blood cells, like that. So you gained PRP clots. If you need to obtain PRF membranes, just use pressure box like that, and with the light metal plate, compress these clots, and after 5 minutes, you will gain membranes. Another type of platelet concentrate is platelet-rich powder. The method is the same, but at the end, you will gain powder that you could use like some, instead of bone material, to filling bone defects. So let's see how to use these different types of platelet concentrates. Here is the patient with radicular cyst, and we show filling of bone defects with platelet-rich powder, platelet-rich fibrin. You can use just only clots, or mix these clots with some biomaterial, like allogenic, synogenic, or some synthetic. Here's some X-ray. Okay. Before and after filling with the PRF. Here is another one, also radicular cyst, but here we filled bone defect with platelet-rich powder, and it is the result after 2 years. Here is the same odontogenic radicular cyst on the right side with acute sinusitis. So here we also use PRF and bone material. So we mixed it. How also we could use PRF, especially LPRF or advanced PRF, for ridge preservation. For example, after tooth extraction. So here is the protocol that we show in picture. So there's some references that we used. So after a traumatic tooth extraction with maximal preservation of alveolar bone, you need to prepare envelope between bony borders of socket and surrounding soft tissues. Then place minimum 3 plugs of LPRF in the socket, one by one. And if you have some superfluous serum, just absorb it with the gauze. Cover the socket with at least double layer of PRF membrane and slide their margins between soft and hard tissues around the socket. So suture with internal mattress or external mattress technique, not with the tension to close the wound, just to keep the membrane in place without traction. Here there are examples of patients with ridge preservation after tooth extraction and results after 1 year. So here we didn't use any bone materials. It's only just LPRF. Next, cases when you could use platelet concentrates. During lateral window technique, I mean sinus lifting and simultaneous implant placement using PRF as sole grafting material. You could use it mixed with some bone material, but also can use as sole grafting material. So here's some protocol. If you want, you could take a picture. The crystal incision, reflection of the trap, then you preparing lateral window and elevate Schneidering membrane, and after careful preparation of the osteotomy, but before implant placement, please put LPRF membranes. They should be placed covering the Schneidering membrane, and make sure that at least 3 layers of PRP are covering this membrane. Also, you could place some membranes against the palatal, mesial, and distal walls of the uncovered sinus. And after all, insert implants, put implants, and add some extra PRF membranes around implants in the sinus and buccally. Cover the window, lateral window, at least with 2 layers, and suture, that's all. Another cases where you could use PRF, it is gingival recession coverage, or for increase the width of keratinized mucosa around implants. Here the case when we used PRF membranes to increase the width of keratinized mucosa around placed implants. So that's how it looks like. Another cases, more in maxillofacial surgery. It's closer of soft tissue defects with the PRF, and also you can use PRP. But first of all, after removing this excessive soft tissues, as showed on this slide, this patient, like you guys, two groups had at the beginning of the lecture. Do you remember? Here there's rhinophyma. So we are closing this soft tissue defect after operation by PRF membranes, and then spraying, rinsing it every day by PRP. So that's how it looks like during 6 months of post-operation period. The first immediately after surgery, then during month is how this wound is healing. Other here. During 6 months after use of PRF membranes. Also, there are some methods of injection of PRP and treatment of neuralgia, just making nerve block. And the last method and way how we use in our daily practice, it is injection of PRP for post-operative wound healing to soft tissues. Because as you know, there are too many trials that shows how to use PRP and PRF in maxillofacial surgery and oral surgery, and they all working with bone tissue. They are put into some bone defects or to sockets or using with implantation, etc. And so few which is describing effects of PRP to wound healing in maxillofacial region. So we have some results of our investigation. So injection of PRP for wound healing of soft tissue and improving aesthetic of scars. So I will be quick, I guess, plus time. So shortly, we had different patients, 50 as a patients of treatment group and 50 as a control. In treatment group, we used injection of the PRP. And all these patients had been predicted to have high risk of complications in their early postoperative period of time. So we had some formula equation that helped us to predict. And then here is our evaluation methods. We used planimetry to compare this group, not only micrometer, but also ImageG program to be more objective. Also, we used histological analysis to compare healing process in these groups. revealed concentration of different types of cytokines like inflammatory and pro-inflammatory, ultrasound and color Doppler ultrasound to examine these two groups, and also we used assessment of postoperative scars after 1 and 3 months by scale, which is called POSSES. And which is interesting, the doctors assess these scars after operations, and patients gave assessment to aesthetic part of the scars after operation and maxillofacial regions. They give some scores. Also, after 1 and 3 months, we had dermatological, some scale of dermatological quality of life index and assessed it in 2 groups. And I will say that results in the treatment group was better. In the group where we used injection of PRP during procedures in maxillofacial region, during some plastic surgeries, reconstructive surgeries, etc. And the width of the scars was less in this treatment group, and mean values of the width of postoperative scars after 1 month and 3 months was less in treatment group by using micrometer, and in this table by using ImageG program. According to cytology, we see that fibroblasts appeared early in the treatment group. As you see on the right side, that's the swabs from patients of the treatment group. And here collagen fibers also we saw earlier and a higher amount. And of course, the epithelial cells in treatment group, as you see on the right side, there were higher, and they are surface cells with pneumatic nucleus and non-nuclear cells, while in control, they are small amount of epithelial cells. So here there are some results of ultrasound examination. And I want to say that in treatment group, results were better, less edema, less infiltration, and presence of lymphostasis. According to scale, when doctors and patients gave scores to their scars. So this is after 1 month, and I will just move on and show different scars, pigmentation and thickness. And I want to say that in treatment group, results was better. So in conclusion, the use of PRP and maxillofacial surgical interventions was effective methods in the improvement of postoperative wound healing. And coming to beginning of this lecture, as you remember, I asked that here we have 2 groups, the same patient, and one of group was successful in treatment and the other one was not. So what do you think? Why the same method, the same patient, but results are different? Okay, I will just think about it and remember all these parameters that I mentioned before about time, about speed of centrifugation, about how works platelets, how it's activated, to be sure that you used proper and right method and it works, and all growth factors in your platelets is activated and working on patients to get good effects of treatment. Thank you.
Thank you, Doctor, for the great speech. Do we have any questions for Dr. Yulia?
Thank you for a very informative presentation. This is Bayan, dental student from Sweden. I have a question regarding the sinus flora elevation. What we learned is that once you lift the membrane, you induce bleeding, and that in itself induces the process of bone formation. So my question is, why would you add PRP, for example? Thank you.
Why we don't add PRP? So we put PRF in case of sinus lifting. So you need to put obtained membranes, not clots. So you elevated this membrane, and honestly, in our practice, we use membranes and bone material and mix it because the result is better when you use PRF as a sole material. But there are some protocols that is known worldwide that some doctors and surgeons use during sinus lifting, so lateral window opening, especially during lateral window opening, only PRF as just sole material.
Thank you for the answer. But my question is, why do you need PRF at all? As I said, once you lift the membrane, the bleeding in the created preparation is induced, and that in itself starts the bone formation process, as long as I know. What's your take on that?
It will not be enough. So this is empty space. So when you use membranes, it will stay there in this place after elevation longer than just only blood clot. So also these membranes, if you gain it correctly, will obtain some growth factors in bigger, higher amount than just only blood clot. Okay, so it's some issues of also implantation, also recovering the membrane to avoid the perforation, etc. Okay, does it make sense now?
Yes, thank you so much. I have another question, if you have the time now. Regarding cyst cases, do you always use PRP or PRF, or just in case of big cysts that maybe require bone resection? Thank you.
Nowadays, we almost always use PRF clots with bone material in case of big cysts or big bone defects. We are mixing it because PRF clots, they have growth factors, and also they induce and help to when you mix it with some bone material, allograft or xenograft or some synthetic, to work better. So there are a lot of researchers that comparing the use only of PRF, only of clots, membranes, or only of bone materials. And the best result when you mix it together. So you're improving this osteointegration in this place.
Thank you so much.
Thank you for the question. We can take one more. There you go.
Hello, ma'am. Thank you for one of the finest presentations. I am Dr. Navneet. I am from India. I have a small doubt that what is your opinion regarding the antimicrobial activity in the PRF? Like you talked about the cases of radicular cyst or post-traumatic extraction. What is your opinion regarding the antimicrobial effect of on PRP?
Could you repeat, but slowly?
Okay.
Or I have one option, because I know time and other speakers also want to show their presentation. Could you write this question, okay?
Okay.
I will read and answer it at the end, okay?
Thank you.
All right. So thank you for your questions, and thank you, doctor, for the great speech.